Wonderful. Lovely. So recording is now started. Thank you all for attending. We'll be asking for a poll at the end and there should be some CPD opportunities. So I'm going to pass over now to Shruti to start the webinar.
Thanks very much, Vicky, and welcome everybody. And joining me today on this webinar is Dr. Stephen Thomas, who is the Professional Director for JPAC, and we'll get an overview about JPAC from him. Also joining is Dr. Angus Wells, who, in addition to his role as a consultant in donor medicine at NHS Blood and Transplant, also chairs the JPAC Standing Advisory Committee on the care and selection of donors. Also supporting us on this webinar are SHOT team members, and with wonderful IT support by Darren Hall, as well as Raquel from the SHOT team. And we would also like to take this opportunity to thank you for joining us. This will be the last webinar of the year, and thanks for taking the time. As mentioned, the recording also will be available. Also, a big thanks to all of you who have contributed to the safe, reliant blood supply as well, and to all the hemovigilance activities. And over the course of the next 40-45 minutes, we will be covering a quick overview of the transfusion safety in the UK, and I'll be covering that. As I said, Steve would be covering the JPAC overview, and Angus would then be covering safe donations for safe transfusions with a couple of illustrative examples. We'll also signpost to available resources all along the presentation, and we will finish with conclusions as well as question and answers. And as you all know, and you may be familiar with this image from previous presentations, this covers the whole journey of blood, right from when we actually then see the donations are taken from the donors, and 100% of all the blood donations in the UK are voluntary, non-remunerated, then taken through for testing, processing, and storage within the blood establishments, and then packaged and transported to the hospital laboratories. And as you all know, more than 2 million components are issued in the UK annually. We also know how very well there has to be coordination and collaboration between the teams to ensure safety. But equally important is actually the compliance and alignment with the blood safety quality regulations. Also, all policies, practices, and processes must be based on the available evidence and facts. Now, we are all familiar with also the steps at the patient end. This again emphasizes the need for collaboration and coordination so that the right component is transfused to the right patient at the right time. Now, adding to this is also the complexity of managing patients in shared care. Now, SHOT, as the UK Hemovigilance Scheme, collects the reports related to adverse events, including near misses, adverse reactions, and we make recommendations to enhance transfusion safety. Now, here is an illustrative figure which is capturing what is the current status of the safety of transfusions in the UK. And please note that this is a representative image and not accurate to scale. Now, we mentioned 2.2 million blood components, and on an average, we receive around 3,500 to 4,000 reports at SHOT. The risk of serious harm is around 1 in 15,450 components issued in the UK, and the risk of death is 1 in 6, roughly around 63,567 components issued. And it's also important to note that the risk of transfusion-transmitted infection is much lower than all other transfusion-related complications in the UK. And we must also remind ourselves whenever we talk about transfusion safety, there are two things. One is the safety of the blood components, all the ones that we actually transfuse, as well as, considering all the complexity of the process, it is about the process-based safety as well. So we need both of that to be actually present to ensure safe transfusions. Now, this is the framework for safe transfusion that was published in one of the recent annual SHOT reports. Today, we will learn about how decisions are made to ensure safe supply of the blood components to save and improve patient lives in the UK. And I'll pass on to Steve, who will then provide an overview from JPAC.
Thank you, Shruti. Just checking I have control of your slides. There we go. Can you see me? I can't see myself.
Yes.
Okay, good. Thank you. Right, thank you, Shruti. So I'm going to spend about 10 minutes just running through the history and structure of JPAC and how we go about our business. So what is JPAC? We were originally created about 35 years ago and have gone through various different iterations and naming groups, naming titles, until we've ended up where we are now. Since about 2005, we've had the same structure, and JPAC having two distinct remits, one being an advisory committee to the UK blood transfusion and tissue transplantation services, and secondly, providing detailed service guidelines for the services. And I'll cover the difference between those two in the next few slides. Who are we? So the work of JPAC is done primarily by 7 standing advisory committees, or SACs. They were led by expert chairs, one of whom is with us today, Angus, and they are a mixture of clinicians and scientists from across the UK blood services. And you can see from the different remits of the groups that they cover care and selection of donors all the way through testing for immunohematology or transfusion transmitted infections, to the production of blood components or tissues and cellular therapy products. We have a slight gap at the moment in information technology, but that's something we're working on and hoping to kickstart that committee again in the new year. So the standing advisory committees are chaired by these experts and are populated by subject matter experts who are drawn from academia, user groups, and blood services, and also the National Institute for Biological Standards and Control, which is now an MHRA institute. The chairs of each of those standing advisory committees participate in the executive working group in collaboration with members of the JPAC office to form the exec working group. So in the JPAC office, so I'm the lead of that. This is my day job. And then we have Pete, who's a scientific publishing manager. He's a biomedical scientist by background and a postdoc, been with us for about a year. And Gary Mallinson, who is also a postdoc, used to work in prion research amongst various other roles in blood services, and provides safety policy leadership across SABTO as well as JPAC, and I'll cover that relationship a bit further. And we also have Anna helping us in the office. She's on maternity leave just at the moment. So that forms the executive working group, and we report to JPAC itself. We constitute JPAC along with the additional members, who are the medical directors of the 4 blood services in the UK, with the observer status for the medical director of the Irish Blood Transfusion Service, and representation from our regulators, the MHRA and the HTA, as well as a representative from MHRA South MIMS, formerly NIBS, and the UK Quality Managers Group. And so that's JPAC itself, the main committee, and in turn we are responsible to the UK Forum, which is a collaborative group of the chief executives and medical directors of each of the 4 blood services of the UK. So that's our governance structure and how the work is conducted, and the sequence of governance and sign-off and accountability. So what do we do? First thing that we do is prepare detailed service guidelines. And these take different forms. So the donor selection guidelines, then there is the Red Book, the guidelines for the blood transfusion services in the UK. And then there's a series of risk assessments and position statements that we put together. And our guidelines are considered best practice, and they are very highly regarded from around the world. Each blood service in the UK is responsible for implementing the guidelines, and they do have some flexibility to implement them as they see fit, but need to be able to defend that should that be attract interest in audit. With our donor selection guidelines, there are 6 different individual donor selection guidelines that you can see, ranging from bone marrow donor selection guidelines, cord blood, tissue for deceased and live donation, and whole blood and component donation. And then we have the geographic disease risk index as well. So these are used at the front line to assess donor eligibility. If you use the online version, there is an A to Z search, so you can use the search box to look up the relevant entry for donor selection, and it will give you all the criteria as to who you can and cannot accept the donation from, and the reason for whatever the last change to that particular guideline was. The Red Book that we produce is the term for the guideline, and this was this is or was a hard copy of a Red Book that covers the guidelines for all materials that we produce for diagnostic and therapeutic use, all the way from donor care to those product specifications. So the last publication of the hard copy of the Red Book was around 10 years ago, the 8th edition, and we were in the process of updating that for a 9th edition before the pandemic hit. What we're going to do now is just have this as a rolling update process. It will be online only, and we will revoke the 8th edition probably in 2024. And most of those chapters are just some trailing edges that just need to update before we enact that change. Also, just to mention that the website is due an update that will happen in the next couple of financial years, and we will update the website to make it more user-friendly, and the same will go for the donor selection guidelines, which at the moment are sort of presented as an online version of a printed page, and that needs modernizing. The risk assessments and position statements that I mentioned mostly relate to the transfusion transmitted infections, so SAC-TTI. Review these on a rolling program, so every 2 to 3 years this extensive list of pathogens will be reviewed for any new or latest evidence, and for us to then consider whether we need to make a change to our position statement, which sets out where we stand on the risk of a particular pathogen to the supply chain, or when there's any additional change should there be an outbreak. And you may have noticed Mpox on that list, so obviously that was something that attracted a lot of attention and work in the last year or so. We can then make particular changes as necessary to the donor selection guidelines or the Red Book itself. This is a list of our position statements that are all published on our website. We don't publish our risk assessments because they are very complicated and in-depth documents, but there is a list of what our risk assessments are, and they are available on request. And these are some analytics just from last summer as to who accesses our website. And you can see that in a month last summer, we had nearly 200,000 hits on the website, mostly from within the UK. And this includes donor carers at the front line checking donor eligibility for blood donations, etc. And you can also see that the device usage, people are accessing our website are doing this in the majority now from mobile devices. They're not using desktops, and this is another driver for us making this change to our website to make it much more user-friendly for use in modern ways when people are accessing information and guidelines on devices that they just carry in their pockets. So how do we update our guidelines? There is a process where if there is a change request that comes to a standing advisory committee or arises from that routine review of risk assessments, etc., will be discussed by the advisory committee. We have 3 different ways of approving that publication. If there's a minor change, that's something that I can sign off, and we can publish that relatively rapidly. For instance, if there's a change in the geographic disease risk index, that's simple to do. If it's a bit more significant, we'll take it to the exec working group and have a discussion there. And again, we can sign that off at the working group and move that forward fairly quickly. Or if it's a more complicated or detailed change, then that will go to the full JPAC committee. EWG meets 6 times a year, JPAC meets 3 times a year. So there are different speeds at which we can progress these things, which are commensurate with the magnitude of the change that we're making. The process of publishing a change is that a change notification document will be prepared by the office and signed off by the chair of the relevant advisory committee. That will be distributed to the blood services, so the QA departments and colleagues can perform a gap analysis, feedback if they need to, that there's something that's not quite right or practical, and plan their implementation, and then there'll be a coordinated go live. So this is what one of our change notifications looks like. It highlights the change to the current text, so it's very clear and accessible in terms of telling you what's changed. And just to be clear, this is an example here of a change that was made following the FAIR 3 review for donors of tissues and cells, and you can see that there are 15 different guidelines that got changed here, or different categories that got changed here across 4 of the 6 different guidelines, and they weren't all. There's some subtle differences here, so it's very, very important that we get things absolutely right, and it's very clear how we communicate what changes are being made to what set of guidelines, because superficially they do look very similar. In agreeing the time that is needed between the pre-publication and the publication date, we try to balance between how urgent the change is. Is this a significant risk to the supply chain that we need to change quickly, or is it very potentially disruptive? But most things sit in the middle there and take around 4 weeks from pre-publication to go live. And there is one other publication that we currently produce, which is the Handbook of Transfusion Medicine. But again, this is around 10 years old since it was produced, and lives on the shelves of transfusion labs or in lab coat pockets, and is a resource that pulled together existing guidelines from many other sources. But we have recently taken the decision that we're going to withdraw this book as well, because it just duplicates the efforts of other organizations, and people are not accessing and not using printed textbooks in the way that they used to 10 years ago or more. So again, this will be withdrawn in the coming year, and we'll have signposting in place to direct people to the source material rather than drawing that together into one textbook. And then just finally, we're often asked, what is our relationship with SHOT-JPAC, which is the government's advisory committee on the safety of blood tissues and organs. And we do collaborate and work very closely with SHOT-JPAC. And as I mentioned before, we have the lead scientist, Gary's in post at the moment, who sits on with both secretariats to make sure that we coordinate our work plan. And we also have instigated a joint meeting every quarter of the two secretariats to make sure we're aligned. And this table just makes it slightly clearer, possibly, in that the remit of SHOT-JPAC includes organs, for instance, whereas JPAC is tissues and cells, and blood tissues and cells. SHOT-JPAC advises health ministers, whereas JPAC advises the transfusion services. And that third row is somewhere where there is a lot of activity at the moment, and that will be increasing in terms of the interaction between the UK and Europe, because following our exit from the EU and the changes to the EU regulations, which will change from the blood directive to new regulations in future, there'll be a lot of activity here, and it's very important that both SHOT-JPAC and JPAC are aligned on that, and all the UK services are aligned and influencing as best we can our UK government and what contacts we can still have within Europe, such as through the Council of Europe, if not the European Union. So that was a quick canter through JPAC, and with that I will thank you. I'm happy to take questions later. Obviously, that's my email, and the JPAC email is on the bottom of the slides there as well. But I will stop talking and pass over to Angus. Thank you.
Thank you, Steve. Okay. So I'm going to talk about blood donor selection guidelines. A lot of what I'm talking about is relevant for the other guidelines as Steve's mentioned. But I want to take you through what we do and how change arises and how we consider recipient safety within our guidelines. So I want to talk about a bit about what is donor selection, why do we have donor selection in place, how do we actually provide guidance on donor selection, and then a bit about how we've responded to blood safety threats in the form of outbreaks, and particular focus on the COVID pandemic, which is still very fresh in our minds. So just a reminder that BSQR is still around, and within that there's a requirement for blood establishments to put and keep in place procedures for the evaluation of donors, and they go on to specify that includes examination, gathering information from the donor, providing information to the donor, and assessment of the donor and their eligibility to donate. And for me, that encompasses what donor selection is about. And that process has three aims. One is recipient safety. As a blood service, we're always focused on the weaknesses of testing, and therefore donor selection to minimize the risk of infective risk getting into blood supply will act with, is complementary to testing, and it will maximize safety for recipients. Donor safety is important because donation in the UK is voluntary, it's non-remunerated. So we want it to be a safe and pleasant experience for donors. We don't want people to be unwell or develop complications as a result of donation, which could stop them coming back and also discourage other donors from donating. And the third arm that perhaps we sometimes neglect is staff safety. And particularly if we're thinking about, as later on, infective risks, we want to ensure that staff are not exposed unnecessarily to risk during the donation process. There's always a need to balance safety and supply. Obviously, it would be very safe to just defer every single donor, but then we wouldn't have a blood supply. Also, we have to think about the impact of deferral on the donor's career, because sending donors away and not accepting their donation the day that they volunteer means there's a chance that they won't come back again, because they may choose to disengage at that point. You know, if you didn't want my blood this time, I'm not going to bother coming back. So we need to be pragmatic, balanced about deferral so that we don't discourage people, and yet we maintain a good enough supply of the appropriate quality. So just to touch again about the sort of remit of the Standing Advisory Committee, the SAC that I chair, we provide guidelines on the care of people who offer to donate blood. We provide donor selection guidelines to exclude those for who the act of donation would be unsafe, for those whose donation could be unsafe or poor quality for the recipients. And we're also taking notice of the regulatory and legislative environment that we work upon. And we, as part of JPAC, we work particularly closely with the SAC on tissues, because again, that is a group that's providing guidelines on acceptable products, and the SAC on TTI on infections as well, because a lot of the changes will be driven by information about the spread, or what's the opposite of spread? As diseases settle down again, we can sometimes take away criteria that we've introduced in response to outbreaks. Steve's already alluded to the guidelines. So we have an A to Z search in there, and we will take care to try and make the guidelines as easy to find as possible. We spend some time thinking about what keywords and stuff we put into the index. And over the next few slides, what I wanted to talk to you about was sort of the regulations and influences that we have to think about when we're thinking about blood safety and guidelines. And so my first one is BSQR. So this was transposed into UK law in 2005 and still remains in force. Unfortunately, some of those entries, there is very specific donor deferral information within, donor selection information within BSQR. And because those are UK law, it's proven difficult to work around these. And some of them remain significant hurdles for changing our donor selection practice. So one would be hemoglobin thresholds. At the time the UK implemented BSQR, we increased hemoglobin thresholds for donors. We haven't been able to change or consider reducing that back again. Historically, there was concern about cancer being possibly transmitted by transfusion. That has kind of been discounted by some very large epidemiological studies, particularly from Scandinavia. It would be quite nice to think that we could simplify or maybe revoke some of that guidance, but again, it's part of BSQR. And skin piercings such as and tattoos have been downgraded as a risk. We know that certainly in commercial premises, there's good practice, and the risks of blood-borne viruses from skin piercing are negligible in the UK. And we did recommend, SABTO recommended the skin piercing deferral was withdrawn in 2017, but that wasn't possible because it would have required legislative change. So even now, we're still faced with the skin piercing deferral that we would very much like to say goodbye to. Going forward, another influence, and one that's increasingly important, are the Council of Europe guidelines. At this point, is a sort of chicken and egg situation because the European blood directives apply in Europe as well as the UK. The current Council of Europe guidelines tend to mirror the blood directives. But as Steve's mentioned, the blood directives will be withdrawn in a year or two, and the Council of Europe guidelines will have an important role providing some of the technical detail that is currently enshrined in BSQR. And that may mean going forward, we won't be in the situation that some donor criteria won't have to wait 18, 20 years before they can be revised. So that's a good thing, I think. And certainly as we're writing guidelines now, we are often referencing Council of Europe guidelines to see how Europe are approaching problems. You've heard from Steve about SABTO and the influence. So SABTO outputs can, when they're implemented, sometimes require donor selection changes to support their implementation and provide guidance for staff and donors in terms of how we manage the implications of that. So I'm thinking particularly of something like the hepatitis C testing that was introduced a couple of years ago. We supported that by introducing guidance on how to manage donors who test positive for hepatitis C or report hepatitis C infection. There's a very robust horizon scanning process to look for new and emerging infections. I'm happy to say this is something that SACTI rather than SAC-CSD has to do, but it's really comprehensive and very robust process, and it means that occasionally I'll get queries, oh, I've seen online there's an outbreak of yellow fever, there's an outbreak of chikungunya, do you know about this? Do we need to do anything to the guidelines about this? And I can usually confidently say, I may not know about it, but I know somebody who does, and there's a process in place to grade the outbreak information and decide whether or not we need to change our guidelines. And sometimes as we're going to discuss, that may require urgent change to the guidelines. Tucked in with the horizon scanning process, ECDC, European Centre for Disease Prevention and Control, has good data on the spread of infectious diseases in Europe. Europe, of course, is our close neighbour, and many donors will travel through Europe. So over the years, they've been particularly important in terms of West Nile virus data in terms of Europe, and also other threats in Europe, such as chikungunya virus. So really useful. It's unfortunate we don't submit data to ECDC now following Brexit, but the data is still available and informs us. So we have had changes for European guideline for travel to Europe in the last year, driven by some of the outbreak information that's been sourced from ECDC. And there's more, there's quite a lot, it's quite a melting pot. We've got a lot of sources. We have to consider things such as Equality Act, GDPR, ISO, drug information. So that can be from MHRA, manufacturers, medical devices, can all affect donor selection guidelines. And as Steve has already alluded to, the primary output for donor selection is the whole blood and component selection guidelines. So from our A to Z search, what we would then generate is new content. So this is something that went out a year or two ago, which was in response to a change in the drug information sheet for valproate, which is primarily an anti-epileptic, but also used for conditions such as migraine and some psychiatric illnesses. So it was necessary for us to introduce a clear guidance saying anybody taking valproate now has to be deferred. And that was around it. While we might be happy to accept the donor, possibly not for epilepsy, but for other indications, we would be happy, but we're now considered the risk of valproate may be too great for recipients, and that's why we now have a specific guidance against their accepting them. And then another typical change would be reports of new West Nile virus in France led to us updating our guidance for France. The map is just to give you a flavor of geography, not for you to see up close, but a couple new districts within France reported West Nile virus, and we therefore included West Nile virus risk for these areas. The terminology used within donor selection guidelines is technical. We have a traditional formal approach where we talk about obligatory deferral and discretionary deferral, and it's not immediately apparent to new users what that structure means. However, the guidelines themselves are written with the key audience being healthcare professionals, but we know that other people use them. Most blood services will then translate the DSG for other users. So that may be your call center staff who will use approved scripts to manage donor queries, your donor carers out on session, and you may update your donor information resources, your leaflets, your websites, so that the information ties in with the guidelines themselves. And one thing I always like to remind people is that effective donor selection isn't just about the time the donor turns up to donate blood. We want to cover the entire donor journey. What do I mean by donor journey? Well, I've described it in 5 steps where you begin, I'm interested in donating blood. You then, can I donate blood? Yes, I am eligible. I'm waiting to donate blood. I'm at the session. I'm giving blood. I've made a donation. I am now a donor. But this isn't a one-off. If we engage with you and persuade you to stay, we would hope that you will loop round again and again. And so we can divide that into pre-session before the actual donation event, on session on the day of donation, and then post-session when we may have to apply donor selection rules based on the outcome of your donation or the outcome of your testing results. So having considered what donor selection is, what resources and stuff that we have, let's look at what we've done in terms of some resources. Some outbreaks, I beg your pardon. So we'll remember, many of us will remember the Ebola outbreak in West Africa in between 2013, 2016. It was really very intense. A lot of UK health staff went out to support that. And at that time there was concern that Ebola would actually spread much wider and that it may possibly even arrive in the UK. So as we began to consider that, there was a lot of discussion around preventing transmission at session. How would you handle somebody, a donor who presented to session, seeking, not just seeking to donate, but possibly recognize the blood service as a sort of health setting and maybe seeking advice around their illness. So during that time, we introduced the viral hemorrhagic fever guideline into the guidelines. And we also began to explore, for the first time in recent history, convalescent plasma collection. At that time, I was working in Scotland. We certainly did one convalescent plasma collection, and I'm not sure if England did any or not. But obviously, convalescent plasma became a much bigger thing post-COVID. And then the other outbreak that was interesting from a donor selection point of view that I want to bring up was the Zika epidemic in the Americas in 2015 to 2016. So from a donor selection point of view, there was particular concern around the Olympics, which were due to take place in Brazil in 2016. And so there was concern that travelers going to the Olympics could possibly bring back Zika, and there may be a risk to the blood supply. And so what we ended up was a rapid implementation of donor criteria, including questions regarding sexual partners, because it became apparent early on that sexual transmission of Zika was possible, and that there was concern that if you were a donor and your sexual partner had been traveling in the Americas, it's possible that you could be infected with Zika and bring that back, and there was concern for transmission. So that was interesting, because not only did we introduce a rapid change, that's what donor selection does, we're quite used to that, but also we were doing a rapid change around an area where perhaps we were slightly more sensitive, which was around sexual partners. So in terms of responding to outbreaks, what we often talk about is initially would be increased stringency, so making it more difficult for people to donate. And often that will be deferral criteria based on travel or location and or symptoms and test results. So often the two things together may come together. And we would also update the country listing, the relevant countries in the GDRI, to say, you know, there is a risk of Zika, there is a risk of Ebola in this country. Make sure you apply the correct donor selection criteria. But what's also important is we don't just bring in the guideline, we continue to monitor that as the outbreak spreads, as the outbreak settles, and as new evidence comes in. And I think it'd be interesting for us to work through what we did in the first year of COVID in terms of donor selection guidelines, to show you how guidance changes as the story changes. So perhaps what I'm wanting to send you away with the message is donor selection isn't static. Donor selection will change, and change frequently so that we make the best possible decision at that time. So we head back to January 2020. This was the first change that we made in regard to COVID. And we introduced a 21-day deferral after contact or travel to a coronavirus risk area. And at that time, we had a 3-month deferral after recovery from COVID. And this was an early response. At that time, COVID was only thought to be in China at that point. But actually, barely 2 weeks later, COVID had spread to another 8 countries, and we therefore updated the country listing to include a further 8 countries, as well as China, to have coronavirus risk. And then shortly after that, we then made sure that airport transfers were also included in the risk area. Historically, we tend to exclude airports because they tend to be air conditioned. You would be unlikely to get a mosquito bite inside an airport. So for most travel risks, which are mosquito spread often or insect spread, However, with COVID, the difference is, of course, that's person-to-person spread. So it's important that we clarified that airport travel was part of the risk. As the evidence evolved, a week later, we came back with another update, increasing the deferral after travel to 28 days. But at the same time, we reduced the post-recovery deferral to 28 days, down from 3 months. So we were getting more evidence at that point about how long viremia persisted and how long the incubation period was. So we were able to change the figures at that point. And many of us will remember, COVID continued to spread rapidly. And so later in February, we added 6 further countries, including Northern Italy. A week or 2 later, we then extended the COVID risk to all of Italy. But by the middle of March, COVID had reached the UK, and therefore the travel criteria were no longer relevant, and the entries were overhauled to take account of the UK response and to start mentioning recovery and the requirement for isolation. And therefore, we were able to remove the risk areas from the GDRI because they were no longer relevant. I'd mentioned briefly on Ebola that we'd done a little bit of convalescent plasma collection at that point. So we made some changes to guidelines to support convalescent plasma collection in May, because that was beginning to start. In June, deferral was changed again with an increase. And then later in the year, a relaxation was introduced to accept plasma donation from donors who had themselves been treated with convalescent plasma. And this required a derogation because the current guidelines are that we exclude anybody who's been transfused because of variant CJD risk. And by the end of the year, we were able to change the entries once again to remove reference to quarantine or self-isolation because that was no longer UK practice. And then we finished up at the end of a busy year at the end of 2020 by having specific advice around COVID vaccination and how that would impact eligibility. And at that time, we required a 7-day deferral after vaccination, not because we were concerned about viral particles entering the donation, but because we were concerned that post-vaccination reactions may generate post-donation calls that might lead us to discard the donation because we could ascertain if the symptoms the donors reported were genuine infection, which required recall of the units, or whether they were due to the vaccination. And so in 2020, there were about 16 change notifications related to blood. Next year, there were 2. Last year, there were 4. And so far in 2023, we haven't had to make any changes to the coronavirus entries to date. But as we get near the end of December, I think we might stick with 0. So possibly from a donor selection point of view, this is almost over. So I hope I've covered all the topics I suggested there, and I'd like to finish there and thank you for your attention.
Thanks very much, Angus and Steve. And so this slide has the website, as well as if people like to scan the QR code, that will take you to the JPAC website. And as always, we now have the date for the SHOT Symposium. So the SHOT team are excited to announce that Tuesday, July 9th, that'll be in Manchester again. Please save the date, and registrations will begin in the new year. And so now we can open up for questions. So we do have some questions coming in the Q&A, so I'll stop sharing and we can start answering those questions. So over to the SHOT team.
So thank you very much. It was very interesting. Please put your questions if you have. Don't miss this opportunity to ask through the Q&A. So the first question that we have, it says, how can we make the blood donation companies successful at university level? Any tips or ideas, please? Thank you.
I'll make a start on that. So currently I work for NHSBT. As some members of the audience may know, I used to work in Scotland, and Scotland did have would often do university sessions. They can be hard work because there's a lot of new donors attend a session. So in terms of making it work successfully, often it's about offering appointments, offering eligibility checks before the donor turns up, and providing pre-session advice about eligibility, how to prepare for your donation, and try and proactively handle some of the common reasons. So if you're dealing with a young audience, you may have, particularly female donors, may not be that, may be borderline body weight, so that you be useful to have some discussion about that. Tattooing, piercing, maybe a risk, is maybe an issue as well. Sexual risks and travel as well can cause problems. So it's about being proactive and engaging, getting your recruiters to engage with the community, the university campus community, before the actual event itself. And also on the day, you will need to consider that there's a lot of new donors there, and you may need to change your normal staffing mix to deal with that. Thank you. That's all I can say off the top of my head.
I think if I can come in, I'll just like to use this opportunity to also highlight the constant need for blood donors. And I think, again, we only have around 7 to 8% of the eligible UK population who are registered as blood donors, and many of them may not return as well. So I think this is a plea, and we need to start young. I do agree. And I think with that caveat that we need to actually ensure donor safety, and there is a higher risk of deficiency anemias when we start younger. So it is actually appropriate advice about the dietary and getting them to be regular blood donors. So a plea for everybody who can either be blood donors or be blood ambassadors to actually ensure a sustainable blood supply as well. Thank you.
Okay, thank you very much. I'll answer the next question that's come in. So this is about the SACC-SD meetings. How often were these held during the pandemic, and were the updates made outside the meetings, or was it all business as usual?
The attempt, I'm hesitating slightly because I went off sick towards the end of that year, but up to that point, we had continued to meet virtually, but a lot of the discussion was going on between meetings, but we were still doing what we could to try and follow due process by consulting with our members, and also ensuring that everyone had sight of the changes as they were being made. And because not only do the SAC help with drafting changes and whatnot, we also look to them to be experts and ambassadors for the guidelines within their respective services. And we have representation from all the services. So yeah, like all meeting committees, things were quite disrupted by the pandemic, but we did our best to try and follow process.
Another question. So how do you determine which drugs are eligible for blood donation, or the donors who use the drug need to be deferred, and how long?
Okay, so within UK guidelines, we have a fairly pragmatic response to most medication, and we tend to focus more on the rationale for treatment rather than the drug itself. There are some specific drugs, such as valproate, that I've mentioned. In valproate, the manufacturer actually introduced into the drug information sheet a statement that individuals taking the medication should not donate blood. So we wanted to implement that. For other medication, particularly those that have, the trigger point is often if there's a formal pregnancy prevention program for anyone taking the medication. That tends to mark the severity of the teratogenicity, then we use that as a flag to introduce a specific deferral criteria. But for most other medication, we're fairly tolerant of donors on medication, provided they're well, provided they're not running into too many side effects, they're not running side effects in the medication, and that the underlying indication won't stop them donating.
Fab, thank you. Next question that we've got in here. First, they're thanking you for a wonderful talk, which I'd echo. And they're saying, what is the latest information about electronic donor selection criteria? Do you think that not posting the paper version to donors' homes ahead of the session has impacted compliance?
I'll try that one, Angus. So that's not a JPAC matter as such. That's down to the individual blood services. So speaking for NHSBT, where I've worked for years, there are plans in place, and that is work that's ongoing. I think in the Welsh Blood Service that there is already an electronic donor safety check in place. I'm not sure about Scotland or Northern Ireland, but it's something where the different services are operating differently. The question's disappeared now, but so is there something about not posting the donation safety check out to donors ahead of session and having people arrive and have it printed, and whether that's impacted on session deferrals?
Yes, that was the back end.
Okay, thank you. It's a good question. I'm not sure if the services or NHSBT, for instance, have tracked that, whether that, because it's definitely something that we're keen to avoid having on session deferrals, because that just slows everything down, doesn't it, and is inconvenient for the donors and the session productivity alike. So it's a really good question. I don't know the answer to that, but I would hope that the marketing or donor experience people behind that are monitoring that. If you could email an electronic version or send that to a device or an app, that would obviously be the most preferable way of working in the modern day.
Thank you. Another question. So there are any particularities with donors of Black descent?
I can start to answer that. I mean, NHSBT are committed to increasing the number of Black heritage donors that we have. There are some issues that we have to deal with, particularly from donors who lived overseas. We may have to deal with historical risks, such as residence in a malarial country that will require testing. We are also aware that there is a difference in hemoglobin level for Black donors. So Black individuals tend to have a lower hemoglobin at a population whole, which is more than just, it isn't due to iron deficiency or ill health. This is just their normal level is lower. So that can be challenging, particularly if we're up against the BSQR requirement that your hemoglobin must be 125 or 135. So that can be challenging as well. Historically, there had been issues around anyone who'd had a sexual partner from sub-Saharan Africa. That, unfortunately, was dismantled a couple of years ago as a sort of second part of the FAIR study, which drove a really comprehensive revision of some of the sexual risks in relation to donor selection. So yes, it is slightly different taking donors from Black donors, but we are always exploring, keen to try and engage and encourage the recruitment and retention of these donors.
If I could just follow on with that. So Angus mentioned malaria. That's a question that comes up a lot. We have quite a cumbersome deferral system, as was mentioned, for people who were born or lived in an endemic area, or were resident there, or have travelled there, and that is something we're looking at the moment, and we've got a meeting next week to start looking at that in a bit more detail, because there are a couple of nucleic acid tests that have now been CE marked that there's potential that we could possibly use that. And there is interest globally as well. I had a conversation on Monday with someone from the Canadian Blood Service, and they're quite a long way through their review process, having had a transmission fairly recently as well. So we're looking at that very closely, because we know there is a potential opportunity to use new technology to enable more people to donate safely, but we have to be careful around how we do that. But that is the objective, is to be as inclusive as and safe as possible.
Fab. Thank you very much. I'm just going to sneak in the last couple of questions here, I think. Next one is asking about herbal and naturopathic products. So how do you decide on the eligibility for people who are taking those and the various ones that are available?
Again, similar to other medication. Sorry, I'll answer this. I hope that's okay. Again, like other formal drugs, we would use the same process. Why are they taking it? What's the indication? Are they well on it? And normally we wouldn't reject donors on these treatments. We do have a... No, that's fine. That's all I need to say. Thank you.
Thank you. Another one. So is it possible to prepare leaflets for donors for universities, as there are lots of biomedical science degrees and students around the country? This would help recruitment process.
So the services all have donor marketing, donor experience type departments, and it would be their responsibility to prepare that sort of target information. So yeah, so that should be possible, but it's not in our gift.
Thank you. I think I might say this is the last question. If anybody else has got any burning questions that we've not got round to, please email them in if you're really after an answer, and we'll try and get an answer to you. So the last one that's got more interaction is just asking about the skin piercing deferral. It was mentioned that the UK have very safe premises, but what about donors that have had tattoos and piercings abroad? Would that come into consideration?
Yes, it would. So the recommendation in 2017 was to allow skin piercing if it was in a commercial premises in the UK, and that was based on the public health or council inspection and regulation of those premises. So we would not have had the same criteria if you reported that you had your piercing or tattoo overseas. So we would have returned to the previous historical deferral, 4-month deferral for those, unfortunately.
Thank you.
And again, with these things, it's often about lack of evidence rather than there being a perceived genuine risk. So it's because we are quite precautionary without good evidence saying it's completely safe, and because by its very nature what you're describing is quite a disparate group, we probably would be very hard to have a universal guideline. Sorry, last question perhaps.
That's okay, that's great. Thank you so much for all those great questions that came in, and as Vicky said, apologies we've not been able to answer them all during this session. We might ask Steve and Angus nicely if they could reply directly to any of you, or failing that, if you do have any other burning questions that you think of, please do send them through to us at SHOT, and the email address for us is shot@nhsbt.nhs.uk, and we'll do our best to answer them for you. So in this last minute, I know we're running slightly over, we're just going to do a quick live poll, and we'd really appreciate you taking a few minutes to complete it, as it does help to guide our future webinars. So the poll is up on your screen now for you to submit answers. Once you've selected your answers, you'll see at the bottom right there's a submit button. So I'll leave you to do those. And while you're answering the questions, I'd just like to remind you that this session's been recorded and it will be updated to our website as soon as possible. And we really do appreciate your feedback and comments and suggestions about haemovigilance and the work that SHOT does. So please do get in touch with us by phone or by email. You can visit our website, which is www.SHOT-JPAC.org, to see all our reports and resources, and a reminder that those are freely available to help you with your transfusion education activities. And we're regularly updating the videos on there. We have shot bites and shotcasts, and comments and suggestions are always welcome on those, so please do have a look. If you're not already aware, we do have an app as well that you can download. So if you just put SHOT UK in capital letters in the search button, you'll be able to join the app, which has all the same information as the website. So do keep an eye out on our website and our app and Twitter or X or whatever it is now for our next webinar, which will be coming in the new year at some point. And finally, a huge thank you to all our speakers today and all of you for joining us. We hope to see you again soon, and we hope that you all have a very safe and happy and peaceful Christmas and New Year. Thank you very much, everybody.